27-year-old male, resident of Trivandrum, Kerala. He is an auto driver by profession. He came with the chief complaints of a non-healing ulcer on the inner aspect of the right cheek near the last lower since 2 months. Difficulty as well as difficulty in mouth opening since 1.5 months. Coming to history of present illness, my patient was apparently asymptomatic 2 months back when he developed a non-healing ulcer over the right side of the cheek on the aspect near the last lower tooth, which was insidious in onset, gradually progressed to the current size. My patient also complained of difficulty in mouth opening since 1.5 months, which was insidious in onset, gradually progressing. It was associated with pain, which was dull aching, non radiating, aggravated on chewing, and it was relieved with over the counter analgesics. The patient also gave a history of difficulty in chewing. History of loosening of the tooth was there. That is the last lower tooth. There is no history of burning sensation in the mouth. There is no history of sharp teeth, ill-fitted dentures, or bleeding. There is no history of ear pain, no history of numbness, altered sensation over the lip or the chin area. There is no history of difficulty in swallowing or pain in swallowing. There is no history of neck swelling. There is no history of cough, hemoptysis, bone pain, abdominal pain, or significant weight loss. Can I proceed?
So are you done with your onset duration progress?
Yes, ma'am.
So, so you said that the patient had difficulty in mouth opening since 1.5 months.
Yes.
For this particular case, what does it lead us to?
In this particular case, it can indicate that there may be masticator space involvement, and it is an advanced disease, which is why the patient has a difficulty in mouth opening since 1.5 months.
So, if the same patient probably had difficulty in mouth opening since, say, 7-8 months, or maybe a couple of years, are you leading us to something else? Does the duration matter?
Yes, ma'am, the duration does matter. If it is a long-standing difficulty, as you are saying, then that can be because of oral submucous fibrosis. But if the duration is of a shorter period, then that can be because of the advancement of the tumor or the lesion.
Apart from infiltration, any other reason why the patient could have difficulty in mouth opening in such a lesion?
Spasm of the medial pterygoid muscle as well.
And have you made a point in your history to suggest whether it's spasm or infiltration? I gather you've made a point, but I hope you're aware of what point you've made.
The pain.
Yeah, pain and something else. You said that it gets relieved on analgesics, right? Yes. The trismus gets relieved.
Analgesics.
Okay. Is Dr. Shwetab or Manish there?
Hi, Dr. Mitali, I'm there.
Yeah, so is there anything else that you would want to... Beg your pardon? Sorry?
You can go ahead. From my side, it's fine.
Okay.
From my side, it's fine. From my side, it's fine. She can go ahead.
Okay, sir. Yes, sir. Coming to the past history, there is no significant history of any medical disorder or comorbidities. There is no history of drug allergy, previous surgery, or cancer. Coming to the personal history, my patient gives history of smoking, that is 10 cigarettes per year for 20 years, and has stopped around 2 months back. The patient also gives history of consuming betel quid with tobacco around 2 to 3 times a day since the past 5 to 6 years, and has stopped 2 months back. There is no history of alcohol consumption. He has a mixed diet with a normal bladder and bowel with no sleep disturbances. The patient gives no history of multiple sexual partners or IV drug use. Family history is not significant. Coming to the summary of the history, a 57-year-old gentleman with no major comorbs and multiple habits presented with a non-healing ulcer over the right side on the inner aspect of the cheek near the last lower tooth since 2 months, which was associated with a loose tooth as well as difficulty in mouth opening since 1.5 months, which was associated with pain. Coming to the general physical examination.
One sec. Again, if I could ask you some specific history, is there is there a note, or could you give us a pointer towards high infratemporal fossa involvement apart from trismus, or pointers towards unresectably? Very subtle, but are there any described pointers?
Any cheek swelling, which is cheek swelling going up to the zygoma or beyond the zygoma.
On history.
If the patient is complaining of a cheek swelling near the ear, maybe.
Not really. I mean, that can be very subjective. On history. Apart from trismus.
Ma'am, I'm sorry, I cannot.
If the patient complains, or if on direct questioning, the patient says that he has significant nasal, significant nasal dryness or dryness in the eyes, does it suggest anything? Or decreased sensation near the palate, does it suggest anything?
There decrease maybe because of the as in if there is pterygopalatine for the
correct pterygopalatine fossa. Yeah. So what does the pterygopalatine fossa have?
So the in contents, ma'am.
Yeah, obviously. I mean, what are you pointing towards?
The contents of the pterygopalatine fossa is the pterygopalatine ganglion. It has the maxillary artery as well as the maxillary nerve.
The artery has nothing to do with the ganglion. Oh, yeah. Sorry. Yeah. Okay. Yeah. So yeah, maxillary nerve, and it also relays the.
Will
just read up. So it also relays the greater petrosal nerve, which. And okay. Sure. I think I'm okay. You can proceed further.
Yeah, I wanted to ask something. Like, as we have touched the topic of pterygopalatine fossa, what are the spaces connected to it, which makes it of quite higher significance in terms of operability?
The connections of the pterygopalatine fossa, anteriorly it is connected to the orbit via the inferior orbital fissure. Posteriorly, it is connected to the middle cranial fossa via the foramen rotundum. Then via the pterygoid canal, it goes to the foramen lacerum. Then the pharyngeal canal is then with the oral cavity, it is with the greater. I'm sorry. Most importantly, it is connected to the infratemporal fossa via the pterygomaxillary fissure. It goes into the nose medially via the phenopalatine foramen, and with the oral cavities with the greater, it contains the greater and the lesser palatine vessels there.
It's partially correct, but I think there are very specific landmarks and 7 spaces which it's connected to. So just read up. I think it's just one of the important questions in the exam. And I think what Mitali madam added, actually, one more thing I would add is also you should know the preganglionic nerve and the postganglionic nerve for all that three ganglion which is there in the head and neck region.
Okay, sir.
So, speaking of spaces, what all is a retromolar trigone? Which all spaces does it open up to, or does it have connections to?
The retromolar trigon, so now in posterior, like as in posteriorly, it will it can enter into the masseteric space via the pterygopalatine, whether via the
Sorry, come again. Masseteric space. Which space? What space is it called?
Masticator.
The
masticator space.
I'm sorry, the masticator space.
Okay. Then anteriorly?
Anteriorly, it can go into the lower alveolus. Then medially, it can go
lower alveolus. We're talking about spaces here, very specifically.
Ma'am, laterally, it can go into the buccal space. From the buccal space, it can involve the buccal pad of fat. Then from there, it can go into the retroantral fat, and then from there, it can go into the ITF.
Excellent. Okay.
And also, it is and postro medially, it is also related to the parapharyngeal space.
Yeah, and but that is.
Sorry.
Yeah. Okay. Fine. Granted. Parapharyngeal space as well.
Medially into the tonsil.
So it's the important point is the upper part. There is no point of resistance to go into the ITF. So you have to be really careful in planning your surgery in these cases.
Yes, sir. Coming to the general physical examination, the patient has a moderate build and nourishment, well oriented to time, place, and person. His performance status is ECOG 0, afebrile. His height is 166 centimeters, weight is 55 kgs, BMI is 19.9 kg per meter square. His vitals are stable with no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Systemic examination is within normal limits. Coming to the local examination, on inspection of the oral cavity, the orodental hygiene is poor. The mandible is dentate with a few missing teeth. The patient has a moderate trismus with an inter-incisor distance of around 25 mm. There is no ankyloglossia. Tobacco staining of the teeth is present. There is an ulceroproliferative lesion of approximately 3 into 2 centimeters present in the right buccal mucosa. Posterior extent is at the retromolar trigone behind the third molar, and anteriorly it is up to the right mandibular second molar. The lesion is abutting the superior and the inferior gingivo-buccal sulcus. The buccal and the lingual plate of the mandible appear to be involved, and the tonsillar pillar, anterior tonsillar pillar appears to be free. The floor of the mouth is free. The ulcer appears to have a irregular surface, and the edge appears to be rolled out and everted. The rest of the oropharynx and the oral cavity appears to be normal. The skin of the cheek, there is no ulceration, fungation, sinus formation, or edema or swelling which is noted. Coming to my palpation, the findings of inspection are confirmed on palpation. Oral cavity palpation, there was tenderness which was present while examining the ulcer. There is no bleeding, and the base of the ulcer shows induration. The right third molar in the mandibular area is loose. There is no loss of sensation over the lip or the mentum. The overlying skin is normal with no swelling or edema. The rest of the oral cavity and the oropharynx is normal. Coming to my neck examination, inspection, there are no obvious swellings noted. The skin is normal with no scars. The laryngeal framework is normal. The thyroid is within normal limits. Coming to palpation, on neck palpation, there is a right level 2 lymph node which is palpable. It is approximately 1.5 into 1.5 centimeters in size. It is firm, mobile, and non-tender. On cranial nerve examination, that is within normal limits, and video laryngoscopy is also within normal limits. Coming to my summary, a 57-year-old gentleman with no comorbs and multiple habits presented with moderate trismus and an ulceroproliferative lesion of 3 into 2 centimeters in the right buccal mucosa, extending just behind the third molar, that is in the RMT area, to the right lower second molar with a loose tooth, as well as a palpable 1.5 into 1.5 centimeter mobile, firm, and non-tender lymph node in the right level. I also have an video of the imaging. Can I play it?
Yeah, go ahead.
Yeah.
So this is a contrast enhanced CT scan of the head, neck, and the thorax, starting from cranial to caudal. The pterygoid plates, the muscles, that is the masseter, etc., seem to be free. There is a lesion which is 1 minute. There is an enhancing lesion which is present in the area of the right RMT, which is infiltrating into the medial pterygoid muscle. There is also bone erosion which is noted in that area. There is a lymph node which was present in level 2. 1 minute. There was a lymph node which was present in level 2, which was approximately 1.5 into 1.5 centimeters, and this was a necrotic node. Coming to my provisional diagnosis, that is carcinoma of the right buccal mucosa. Subsite is the retromolar trigon, and my staging is C T4B N1 M0.
So, Ashima, how will you go ahead with this case?
So
after this, you have done a scan. Then now, what is your next step?
So I would first like to counsel the patient and talk to him regarding the possible diagnosis of malignancy. Once after that, we can go ahead. Now we already have the imaging. Then we can go ahead with a punch biopsy from the lesion. Once we have confirmed the diagnosis, then I can further start prehabilitating the patient, explain regarding speech swallowing exercises, tell him how important it is to continue stopping his habits, explain regarding his nutritional status. After all this, I would like to proceed with a curative intent surgery. That will be a multimodality surgery, which will be surgery followed by adjuvant treatment. My surgical plan will be a wide excision with a right segmental mandibulectomy, with a right upper alveolectomy, with a right modified radical neck dissection from 1 to 5. Plus, for reconstruction, I would like to proceed with a free fibula flap, an osteocutaneous free fibula flap.
So we'll start with the things you have said a word prehabilitation. So what prehabilitation includes? What all things prehabilitation includes in a patient of oral cavity cancer?
So it will start with speech and swallowing exercises. You want to build up even with the nutrition of the patient. Regarding dental care, then the patient should be counseled regarding de-addiction and how he should not continue or how he shouldn't restart his habits. Patient also should be explained regarding the complications of the procedure.
I'm sorry, can I interrupt you? Are we talking about rehabilitation in a buccal carcinoma?
Yes, sir.
Sorry, this is Deepak. I just joined.
Yes,
sorry.
Yes,
sorry,
you can.
I'm sorry. Please forgive me. I'm just seeing your impression. It says right buccal carcinoma RMT T4. And the question was very, very, very valid. in this specific subsite, in a buccal carcinoma, it's not like oropharynx, it's not like hypopharynx, it's not like supraglottis. What will your prehabilitation be in a buccal carcinoma? You're talking general things. You're talking about pre-RT prophylaxis and things like that. But the question asked by sir was very clear. He asked you prehabilitation in a buccal carcinoma. Please identify the two different things.
Yes, sir. Sir, in this case, mouth opening exercises, trismus correction will patient will have a lot of. There is a chance of post-op trismus, and that is what we should be telling him about and counseling regarding mouth opening exercises.
Very good. I accept your point. But that is if patient has pre-existing trismus. Does this patient have pre-existing trismus?
Yes, sir. This patient has a moderate trismus and his inter-incisor distance is around 25 mm.
Okay, so how do you expect to do mouth opening exercises prior to surgery, and how do you expect it to continue it post surgery? Have you ever seen a patient with trismus pre-op been given appliances or low-level laser or low-level ultrasound to improve the trismus? Or has all the evidence been on improving trismus post-therapy?
It's mostly post-op, sir.
Then why did you commit on the prehabilitation with trismus?
Okay, sir.
No, your point is absolutely correct. I don't deny that. You have to teach the patient about trismus correction. I just don't know what, if you diagnose a patient a week earlier with trismus and you're operating him after 5 days, what is the magnitude of benefit in doing prehabilitation in these patients? Your point is absolutely correct. Absolutely correct.
Maybe if as in we're just teaching him a little in advance so that his post-op rehabilitation is better if there is only
yes, correct. So you just want the patient to be informed prior that they have to. But what sir asked was a very important question. What other thing in prehabilitation will you teach the patient? The question asked was very valid, and you also gave a very good answer about preconditioning them about trismus. But is there anything apart from that? Would you talk about consistency of feeding? Would you talk about what sort of pharyngeal movements that are required, specifically in a buccal carcinoma, buccal and RMT carcinoma?
In this case, his since the muscles of mastication will be affected post-op, then his overall the chewing etc. will be affected. So in the post-op phase, maybe we will have to go in for more liquidy feeds rather than anything else. So since
okay. So your 2 points are taken very well. First is advice on trismus. Second is advice on consistency of feeding. What will be your third advice? What do you think is going to happen if you resect mandible, buccal mucosa, and what correct? Somebody wrote it very clearly in the points in the group chat. Yeah. What else? They wrote very correctly.
Yes, sir.
Sorry.
The patient later may have, like, as in malocclusion will be there.
Excellent. Very good. Malocclusion can be there. Excellent. That is the other thing that you have to talk about. But would you consider patients' general well-being if the patient has sarcopenia or the patient is wasted? Would you think that as part of your prehabilitation also?
Nutrition. Nutrition. I will want to try to improve his nutritional status as much as possible, even pre-op.
So, do you think that works in a week?
No, that will not work in a week. Sir.
No, your answer is correct, Amma. Don't ever correct yourself. Your answer is absolutely correct. You will counsel for dietary.
improving his diet. The sooner we
Yes.
start, the better.
Yes. So your 4 points are absolutely correct. One is the malocclusion, second is the consistency of the diet, third is the swallowing difficulties, and fourth is the systemic improvement in his overall well-being. This is all the prehabilitation that is possible, and of course, dental prophylaxis with bad teeth and what extractions are required prior to RT. Excellent answer. I'm sorry, I just joined now. I'm just picking on you. Please continue.
Thank you, sir. Thank you. Mitali ma'am?
Yeah, Ashima, can you tell us what is the first echelon of cervical nodal involvement typically in buccal cancer?
In buccal mucosa, the first echelon node is 1B.
Okay, so and in retromolar trigone?
It goes to level 2.
Okay, so that is in spite of it being one of the subsites of the buccal mucosa, the first echelon of nodes is of a retromolar trigone is by and large similar to that of the oropharynx, that
Yes.
is the anterior facial pillars. Could you define the boundary of the retromolar trigone per se?
So the boundary is the base is formed. The base is just posterior to the third molar. The medially it is bounded by the temporal crest, and laterally it is bounded by the medial aspect of the mandible.
Okay, and you said it was a T4B disease.
Yes, ma'am.
By virtue of?
By virtue of that, the patient is giving difficulty. He's giving a history of difficulty since 1.5 months. Number one, and number two, on imaging, when we saw that there was the tumor was infiltrating into the medial pterygoid, that is in the masticator space.
So, is it a resectable disease or an unresectable T4B?
This is a resectable disease. It comes in the criteria of low ITF, or
when will it become unresectable?
Or infra-notch disease. It will become unresectable when it is in a high ITF, that is when you have intracranial involvement or pterygomaxillary fissure involvement. In that case, it is absolutely unresectable. It can be borderline resectable.
Can I correct you there? You're saying pterygomaxillary fissure is unresectable.
Intracranial extension.
Let's get back to this. You said you explicitly said pterygomaxillary is unresectable. Can you tell me what a pterygomaxillary fissure is?
Pterygomaxillary fissure is, as in, it is a space which connects the ITF area with the pterygopalatine fossa.
Okay, so what makes a pterygopalatine fossa unresectable or a pterygomaxillary fissure unacceptable? Has it been given like this in any of the publications that if the pterygomaxillary fissure is involved, it is unresectable? Hello.
Sir, whatever I think I had read was that low ITF, intermediate, and high ITF, and in
no, Kanna, I am only asking about pterygomaxillary fissure.
Yeah, so I think what I read was in the high ITF, it was intracranial involvement and the pterygomaxillary fissure involvement.
Mitali, do you agree to that? We can resect the pterygomaxillary fissure and the medial part posterior to the maxillary sinus and nasopharynx. That would be a part of a complex maxillectomy, but I don't think that defines unresectability. I agree with high ITF, extensive PNS, skull base erosion, involvement of the MCF. All these are, or involvement of the cavernous, all these are criteria for unresectability. But I don't think pterygomaxillary fissure involvement is unresectable. Anybody can correct me.
So, largely, let's, Ashima, because we are doing a case presentation and it's important that you provide safe answers which are acceptable to most.
Yes.
Don't go into, pterygomaxillary fissure per se is an anatomical landmark. and it leads to the fossa. Now, the pterygopalatine fossa also has the high pterygopalatine fossa and the low pterygopalatine fossa.
Yes, absolutely. Okay.
So again, it can go into unless you're very sure of all the contents of all the, as Dr. Shweta was saying, that you should be well versed with the preganglionic, postganglionic, sympathetic, parasympathetic.
That is the
unless you're very sure of it, I would suggest play it safe. But yeah, now that we've gone into it, we've entered into this topic, please read up about high pterygopalatine fossa and low pterygopalatine fossa. Again,
that was what I was trying to say, Mithali. You're absolutely right. It's just like high ITF and low ITF, pterygomaxillary fissure is not a landmark, but the pterygopalatine fossa is a landmark, and there is a criteria for high pterygopalatine and low. Don't get caught up in all this. I only asked you because you said it. I don't think anyone would accept pterygomaxillary fissure involvement being undetectable. But as Mitali said, it's very important to differentiate between fossa high and fossa low. Okay? I hope I haven't said anything untoward. Yeah? Please continue.
I think the one more thing to add here is because it's such a vascular and such a high nerve plexus are there, it is important to see the extension beyond it towards the foramen ovale and all when that fossa is involved. And I agree with what Deepak sir is saying, that it is operable if it's low. If you get a margin anywhere, you can operate, basically. That's the whole point.
Yes, that is absolutely the fact.
Aspect if we are feasible to give to the patient. And it's still a controversial topic, I know, but I'm just saying that kind of, if you know the evidence, is a good thing to say. And also that what Deepak sir said is absolutely right, that there is a meta-analysis on it actually, which talks about there are multiple RCTs which are looked at Christmas rehabilitation in head and neck cancer, and the laser and the ultrasonic therapy has shown some benefit, but not statistically significant. And what is important is the rehabilitation post-op should be quite immediate, within 1 or 2 days, if it is feasible. That has helped. That is what's been shown. But unfortunately, nothing has actually shown a significant benefit in improving that rhythmus.
So what Manish said was absolutely correct, because in today's era, we are talking replacement of like with like. And when you replace like with like bone, you always have to talk about the dental implants and dental rehabilitation. Please read Sidney Ching's article from MD Anderson, where they looked at implantation prior to RT, that is on table with fibula, versus delayed implantation. The success rates of implantation prior to RT are better. The loading is better. The rehabilitation is better. So I missed that point. You have to talk in the rehabilitation about that to the patient, especially if the patient is dentate and they are young. It's an edentulous patient with pipe stem features everywhere. That's not the fact. But Manish absolutely raised the point. We have to talk about dental rehabilitation also. So please continue.
Yes, sir. So
I think, are you waiting for the questions? Then we can go to the questions.
Yes, sir.
So I think let's go to the imaging fact. Obviously, you've done the CT scan. Would you do an MRI? Would you do a PET scan? And what is the evidence against and for?
In this case, an MRI would be complementary. It would give us a better indication regarding the soft tissue involvement that is in the ITF area. It would also tell us if there is any perineural invasion, or if the disease is even a more supranotch disease, then whether there is any skull base involvement. But in this case, mainly to know the extent of the involvement in the ITF area, an MRI may help. Coming to a PET, per se, there is no actual hardcore evidence regarding the usage of PET in oral cavity malignancies, but it can be an additive investigation. It is useful in the case of locally advanced, if you want to rule out distant metastasis. Then in the case of a patient with bulky lymph nodes or with lymph nodes in the lower cervical area, it can also be useful in the case of a recurrence or a residual disease.
Excellent answer. How would you use imaging to decide your mandible resection? Is your mandible resection based clinically? Is it based radiologically? Is it based on soft tissue factors? Is it based on perineural spread? How would you decide your extent of mandibular resection?
The extent of mandibular resection, firstly, we would like to see what is the extent of the bony erosion. Secondly, even the soft tissue component of the tumor should be taken into consideration. And if there is PNI, then it is advised. Then, if the patient has PNI, then the extent of mandibular resection may amount to a hemimandibulectomy rather than going in for a segmental mandibulectomy.
Excellent answer. Do you know the paper, very good paper from Tata, which subdivided mandibular involvement based on imaging?
No, sir.
Very nice paper. Cortical, marrow, canal. Did they subdivide anything like that? So you rightly said you want to see the erosion of the mandible. You want to see the soft tissue extent around the mandible. And then you said you want to look for perineural spread. Perineural spread is clinical, PNI is pathological, whatever clinical. But do you want to see the marrow enhancement also?
Marrow enhancement will we should also see. It will that will also help us to decide that will also help you to decide the extent of the resection needed, and that will be in MRI.
So very good in MRI. So what are the how will you decide marrow extension on MRI? Would you use contrast? Would you use some suppression techniques? Marrow is fat, correct? Marrow is fat, has a high signal in T1. Would you use any specific sequence? And would you look at any soft tissue on the lateral side of mandible to look for marrow involvement and nerve involvement?
Sir, if the tumor is involving the marrow, then it will have an hyper intense signal on T2.
Let's start with T1. It will be contrast enhancing on T1, correct?
Yes, sir.
And replacement of marrow on T1, correct? Yes. And hyperintense on T2. What will you see at the mental foramen area on the chin?
At that, so if there is involvement of the nerve at that area, there will be a widening of the foramen and there may be thickening of the nerve.
Yes, and soft tissue enhancement also, correct?
Yes.
So your answers are absolutely correct. But one critical factor in any mandibular or RMT tumor is to understand how far anterior we have to cut the mandible.
Yes, sir.
Yes, that is decided by like what you said, soft tissue, marrow, and the nerve involvement. So always be critical of that. Yes. Don't always look at that, because it's not correct if we resect the mandible and the patient has recurrence at the stump or marrow involvement going. Posteriorly, you're absolutely right. Posteriorly, you look at the pterygoid de-innervation, you look at enhancement between the heads of the pterygoid, you follow it to the skull base, all that is fine. But one of the important things that you mentioned about MRI is to know the extent of bony resection.
Yeah. Sorry to interrupt, sir. We have time restraints. We have left 7 minutes for this session. So, Mitali,
Yeah, Ashima, so about bony resection, would you resort to frozen section for the bone?
So per se, if we want to use frozen, then scrapings from the marrow can be sent for frozen. That
okay.
idea whether our margins are okay. Intraoperatively, if the bone is bleeding well, that alone will indicate that the bone, that area.
So my point was, as such, the cortical bone really cannot be assessed intraoperatively.
Yes, yes, ma'am.
Okay. I think let's Dr. Shweta, would you want to take over for adjuvant or anything related to for the treatment?
Just one question before we go to advent. We can ask about the reconstruction. What reconstruction you will do?
I would like to do an osteocutaneous free fibula flap in this case to replace like with like.
So. To replace like. Okay. Sir, Sweta, sir.
Ashima, can we quickly go to the histopathology? Have it?
Sir, I'm sorry, I do not have the histopatho of this patient. It's still
fair enough, no problem. So let us say that this patient you operated and did a good reconstruction, and the HPR came out to be a moderately differentiated squamous cell carcinoma, 4.5 centimeter with depth of invasion 8 millimeter, and the single node that you saw came out positive without ENE. And other things are pretty standard, like WQI and 5 and no perineural invasion, etc. So what will your adjuvant plan be, and how will you counsel the patient for the same?
Sir, in this case, is the bone involved, sir?
Yeah, bone is involved. Of course, bone is involved.
So, sir, now we would it would be a PT4 N1 disease. So this patient will require post-op RT. So that is what I would like to proceed with.
Okay, so why do you say this is P? If the bone was not involved, then how will you stage this patient as? Let us say that for hypothetical purposes, let's say the bone was not involved, and the size of the tumor is 3.8 centimeter. What will you stage the patient as?
3.8 with the depth of invasion of
8 millimeter, let's say.
In that case, it would be pathologically T3 disease.
T3?
I'm sorry, T2 disease. Lesser than 2 to 4.
Okay, so you have to realize that when you are restaging, you also have to take into account, like in pathology, most of the time we are not reporting separately whether preoperatively the masseteric space was involved or not. So you cannot just, by looking at the pathology and say that, okay, the size was low and size was small and the depth of invasion was not there, so it doesn't become PT2. You also have to take into account that clinically the disease was reaching up to the infratemporal fossa, right? The masseteric space. So it was a T4 disease to begin with. Just because you have not labeled the pathology specimen like that doesn't mean that it becomes T2. Do you agree with me or not?
Yes, sir.
So if it is PT2, then in this case, would you not consider the patient for adjuvant RT? If this patient is resected by you, this comes out to be a 3.5 centimeter tumor, moderately differentiated, and depth of invasion 8 millimeter, no bone involvement. Let's say WQI5, no LV, no PNI, and let's say N0 also. So will you consider this patient for RT or not?
Sir, N0?
Yeah, N0.
Sir, if this patient is actually a T2 disease and the masticator space is free, then we can consider to leave the patient for follow-up. And
how are you deciding on whether the masticator space is free or not?
No, as in if clinico and radiologically, if the masticator space is...
Let's say in this scan only, so what will you do?
In this case, I would like to give him post-op RT because there is infiltration of the tumor into the masticator space, as well as the patient does have a history of trismus. So it does indicate a locally advanced disease. So I would like to proceed with post-op radiation.
So that's the broad message, right? Just don't go by the pathological report that you have. You should have the complete clinical picture, the radiological images in your hand when you're deciding on the adjuvant treatment, right? You just cannot say, look at the size of the tumor. You cannot just say, okay, this is a PT1 or a PT2, and we don't give adjuvant treatment in this, right?
Yes, sir.
So there is a question which says, would you recommend adjuvant chemo. So I'll change the question. Would you recommend any adjuvant systemic therapy? And is there any recent big trial addressing the same issue? Are you aware of it? Something that's published like 2 months ago?
Sir, I am not aware of the recent trial.
Okay, so I'll just quickly, for the sake of time, I'll just quickly mention the RTOG 0920 trial. That's a long-standing trial. Actually, it started 10-15 years ago. I think 11 years ago to be precise, and that was just reported about 2 months ago, published in Journal of Clinical Oncology. And what it has done is that it has randomized intermediate risk factors, not the high risk one, which means not the ENE or the margin positive ones. It has randomized patients of all head and neck subsites which have one or more intermediate risk factor. Now, as per them, the intermediate risk factors were, if I remember correctly, it was T3 or T4A disease, any N2 disease, it was perineural invasion or lymphovascular invasion, and I think it was T2 with more than 5 millimeter depth of invasion, because it was done by the AJCC 7th edition when the trial was designed, and they randomized patients to receiving RT alone versus RT plus cetuximab, and it was not chemotherapy, it's actually RT plus cetuximab, and that is as of now the only level 1 evidence for adding any sort of systemic therapy in this cohort of patients that we have. Of course, we have multiple retrospective evidence, including the Trifiletes paper and our own paper, but the prospective randomized trial is this. It showed that there is a disease-free survival difference to the magnitude of 10 to 12%, but there is no overall survival benefit. And what the authors have concluded that in patients, if you go through the paper very clearly, they say that in patients with 3 or more risk factors, you may consider adding cetuximab. Otherwise, it has not much benefit. So in this particular case, I don't think there is any role of systemic therapy. Adding only as per the standard available guidelines, we'll do only adjuvant RT.
Yes.
Okay, from my side, Jitendra, about the adjuvant treatment.
If you have done with the questions, I will ask the examiners to give marks to the presenter. Out of 10, how will you rate the performance? Hello?
So, Ashima, from my end, it will be 8 out of 10. But there is scope for improvement, and wish you all the best.
Thank you, ma'am. Thank you, sir.
Manish, sir?
I think the only thing, I think clinically you're pretty good. The only thing is the anatomical aspect of certain fossa and ganglion and all, which we need to improve. Otherwise, you're pretty good.
Okay, sir.
Sweetab, sir?
Very well done, Ashima.
Okay, thank you, everyone. Now, I will ask Amanjot to take over.
Thank you, everyone, for this insightful discussion on the topic. We now move on to the next